So I think the first thing is an escalation approach is not appropriate for every patient with MS, and a key step is prognostication at baseline. So when a patient is initially diagnosed with MS, it's very important to consider their prognostic factors. So indications of more severe disease can include demographic, clinical, and radiographic features. And we're beginning also to consider biomarkers like NFL in that estimation as well. So in terms of clinical features, we know that male patients, patients with older disease, and non-white patients tend to have a more severe course. In terms of clinical features, if a patient has a motor, cerebellar, or sphincter relapse, that can be an indication of more severe course. If they have a short interval to the second attack, or if they don't have a good recovery from the first attack. And in terms of MRI features, if we see gadolinium enhancing lesions on the MRI at baseline, if we see a high T2 lesion load, or if we see a high burden of infratentorial or spinal cord disease. So those are all, more poor prognostic indicators, and that those indicators have to be considered at baseline. So if you have a patient who lacks those factors and in general seems to have a good prognostic profile, then I think, an escalation approach should be on the table. So that would be the first step. The second step is always having a conversation with the patient about what their own preferences are. So people have different preferences in terms of their comfort level with risk and also in terms of route of administration of the medication. They also, there are different issues around cost and coverage in different jurisdictions. So those factors are all important parts of the conversation. And we also have to weigh with each medication the efficacy of the medication versus the safety profile. So we always have, a conversation with our patients about what they can expect in terms of potential adverse events.